Thank you very much, everyone, for joining us on World Patient Safety Day. I've got an expert ISUOG faculty here to answer questions about COVID and pregnancy. So I'm really pleased we've got many of the authors of some of the key papers in this area are joining us just now. And you've been very generous with your time in sending us questions, which we're hoping to answer one by one. And we'll have a bit of a general discussion at the end as well. So thank you very much. I'm going to jump straight into the questions now. So the first question here is to Vincenzo, and it is a question about variants of the virus. So is there any evidence that different variants affect pregnant women in different ways?
First of all, thank you for having me on. This is great, and thanks to ISUOG and everyone. This is such an important topic for pregnant women and COVID. Yeah, there is evidence that, for example, the Delta variant is more infectious. In general, the data in non-pregnant adults is similar to the data in pregnancy. The important thing is that the vaccine covers these different variants so far, as far as we know. So it's really important, as we'll discuss, to give the vaccine to women. Only about 25% of pregnant women in the US have been vaccinated. That needs to increase. But there's also safety data on over 160,000 women in the US reported to the CDC. So yeah, there are different strains that can affect the woman a little bit different in terms of infectious, but the vaccines covered also. I really need to emphasize the need for women to get vaccinated as soon as they can get a handle on a vaccine. And in fact, in the US here, they should even get boosters because some of our women have been vaccinated like 6 or more months ago. So we have one of our fellows who just got a booster yesterday from Pfizer.
Thank you very much indeed, Vincenzo, for that succinct answer. So the answer is yes, there are differences in the different variants, but they're not huge and they are all covered by the vaccine. Let me move on to another question. And again to Vincenzo, if a mother has COVID, does it pass to the unborn fetus?
Yes, but in minimal part. It really depends mostly on the viremia, and viremia, so that the virus in the blood of the mother depends on how sick she is. So in general, the chance that there is virus in the blood of the woman is 1% or less. So in those cases, if you have a symptomatic mild disease, the chance that the baby gets it is extremely small. If the woman gets really sick, she is critically ill, intubated in the ICU, she has pneumonia, then she has a 30% or higher chance that the virus is in the blood, that there is viremia. And those are the cases in general that have been reported rarely to have transmission through the placenta to the baby. There are receptors in the placenta, the virus can accept that and go to the baby. But again, those are very, very few reports, very rare. I think it does exist, but those babies actually did well. So in the rare, very sick woman who passes the virus to the baby, those babies did well anyway.
Just allow myself a supplementary question to you, Vincenzo, that of course, the neonatologist will normally do a throat swab if there's a COVID positive woman, but of course a throat swab picks up passage at the time of delivery, potential mother to fetus, mother to baby transmission, and of course, could represent mother to fetus transmission. So it's all these three possibilities, isn't it?
Yeah, so that swab should be done, right away after birth, and even because sometimes these reports are like 2-3 days, and the mother has had the baby, may have transmitted the COVID virus after, birth. Then, you can do cord blood antibodies, and there are some reports with IgM that's been controversial, but that would, kind of confirm a little bit the transmission. You could look at the amniotic fluid, and there are very few reports of positive amniotic fluid. So I think that these few reports need to have better confirmation, like you said. It's not just a nasal waft after birth because there could be contamination, but you could also study amniotic fluid, cord blood, placenta, and other ways to kind of prove the transmission. And there are a handful of good reports like that in the literature.
Thank you very much indeed, Vincenzo. We move to another question, quite topical, and this is to Asma. And the question is, how do I differentiate COVID from preeclampsia if I don't have angiogenic markers? Now, of course, COVID and preeclampsia are different conditions, but there is some overlap there, and interest in the question of preeclampsia being more common in COVID. Asma, tell us about this.
Well, you're right. The evidence of a link between COVID and preeclampsia is compelling, and that illustrated very nicely by the recent meta-analysis by Professor Romero. So it's not just an association between preeclampsia and COVID, but also it's a dose-response relationship. So women who have severe COVID are more likely to develop preeclampsia compared to those who have mild or asymptomatic COVID. And for the angiogenic markers, certainly would be helpful in differentiating between COVID and preeclampsia, because you would expect in preeclampsia that the SFLT1 level will be increased and the placental growth factor would be reduced. But what about if we don't have access to the angiogenic markers? In this case, we can rely on other clues. So for example, if the woman have respiratory symptoms or fever, that's more consistent with the diagnosis of COVID. And if she has, we can also use imaging, for example, like lung ultrasounds or lung CT scan, where you would expect to see features of COVID compared to if she has preeclampsia. And of course, preeclampsia doesn't get better until you deliver the baby, while actually COVID, in the majority of the cases, you'd expect to get better with the right support and treatment. But ultimately, you have to treat the patient in front of you. So if she has hypertension, you need to give antihypertensive treatment. If she has respiratory compromise, you need to give respiratory support.
We move on to Andrea. The question here is there a possibility of choosing the different type of vaccine in pregnancy? And is there one vaccine that is particularly recommended over another?
Thank you very much for the question. Thanks for the kind invitation. Well, if you look at the literature, you can see clearly that the vast majority of the benefits and also on the data concerning related to the potential safety concerns refer to the mRNA vaccines, which are basically Pfizer and Moderna. So I believe that looking at the available literature, if we have to choose, if we can choose, we'd better opt for either of these two vaccines. Of course, there is no reason why we have 4 options. So if a patient had the Johnson & Johnson vaccine, that's fine. If a patient already had, let's say, a first dose of the AstraZeneca vaccine, she can have the second dose. There is no reason why she shouldn't have this done. But if we can choose, I believe Pfizer or Moderna are the best options based on the available evidence.
Andrea, thank you very much. So the message there is a slight preference you're suggesting, but really there's no concern about any of the vaccines in pregnancy. Good. Let's move on to Ray. So will the booster vaccine protect the unborn baby?
That's a very good question. Thank you. And well, we already know that antibodies passes through the placenta to the fetus, specifically IgA, and that's very important. And when born, the mother passes IgA to the neonate through the milk. But there have been also suggested that after several months, the people will need a booster vaccine because antibodies will decrease through time. And that's very important. However, if the question is that if the booster vaccine will protect the unborn baby, which is like kind of a tricky questions, I will say no, because probably due to the very low vertical transmission that we know, we still don't know there are consequences to the unborn baby. We will protect the baby after it's born, probably yes, but when it's unborn, probably it is not necessary. But anyways, the mother will pass IgA to the fetus, if that's the question.
Thank you very much. Yes, it's a slightly difficult question because the unborn baby, and of course this is all hypothetical, but you gave a very good answer there, Ray. So thank you. Well, let's move to Asma. Asma, what happens if in between vaccine doses, a pregnant woman gets COVID?
We don't know is the honest answer. Like many things during the COVID pandemic, we don't really have robust evidence to guide us. But certainly the current guidance is that if you have COVID, that we should defer the vaccination until 4 weeks from the COVID, from the positive swab or from the start of COVID symptoms once the infection is confirmed. And therefore, in answer to this question, my answer would be is that to defer the second dose of the vaccination until 4 weeks from COVID. I mean, just to maybe talk about the current guidance in the UK, that we have interval of 8 weeks between the 2 doses of the COVID vaccination, but that can vary among the countries. We just launched last month the country's largest clinical trial that would be able to help us answer what is the best dosing interval of the COVID vaccination. But certainly this question, you would say defer the second dose of vaccination until 4 weeks from COVID. An important point just to bring to the discussion is the reactogenicity. That means the symptoms after the vaccination. So we know that if you had COVID, you're more likely to get more severe symptoms after getting the vaccine. And just to put things in perspective, it's not severe that potentially could harm the mother or the baby. But certainly, so number one, you're more likely to get severe symptoms if you had COVID, and you're more likely to get severe symptoms after the second dose of the vaccine. And therefore, if this woman is near the end of the pregnancy and you worry about the potential consequences of severe symptoms, particularly fever after giving the second dose of the vaccine, I think it's also reasonable to defer it until she has a baby. But certainly if it's in the first half of the pregnancy and you want to give the full protection of the vaccine, I think just defer it 4 weeks from getting COVID.
Thank you. So I'll just ask a supplementary there, Asma. So the issue is really to prevent worse side effects rather than a relationship with getting optimum immunity. Is that correct?
Yes, you're absolutely right, because we don't really know whether a pregnant woman would get the same immune protection or the same immune response from having 1 dose and COVID compared to having the 2 doses of the vaccine. And I hope that maybe the BREAKOV trial that we launched last month would help us answering this question. And therefore, I think if potentially defer the second dose after the delivery, if it's near the end of the pregnancy, is more because you don't want to get severe symptoms after the second dose, rather than immune response or protecting the mother or the baby.
Thank you very much indeed, Asma. I've got a question that I'm going to answer myself. So I'm going to ask the question and then answer it. And the question is, what are the genetic risks of being vaccinated? And is there a potential for genetic recombination in the developing fetus? So this actually is quite an easy one to answer. Firstly, the mRNA cannot work itself into our DNA or baby's DNA. So there is no risk of altering the genes of a baby or a mother. So that's very important, because often on social media, there's a lot about making genetic changes to the code of the mother and baby, and that simply is not the case. The second is that the mRNA gets into a cell and instructs the cell to produce lots of, for instance, the spike protein of the virus. So it's just really asking the cell to produce lots of material that becomes immunogenic and stimulates an immune response. And the mRNA does not cross the placenta. So on all those counts, vaccines are safe. They don't affect the genetic code of mother and baby, and they do not affect very unlikely to affect anything in respect of the so that is really the answer to that question. We're going to move on to an obstetric question to Andrea. An obstetric delivery ward type question. Can a woman who's suffering from COVID in pregnancy have epidural analgesia in labor?
Yes, the answer is yes. Women actually should have their analgesia during labor. This is also endorsed in a statement by the Society for Maternal and Fetal Medicine. Mainly the main reason for this is that positioning a catheter for pain relief during in early labor ideally prevents the risk of generating, let's say, aerosol generating procedures in the event, let's say, for example, of an emergency section. So on this basis, women should get their catheter position ideally as early as possible. Of course, in the event of more severe COVID, care should be taken in order to exclude thrombocytopenia or coagulation issues, which have been reported, but this, of course, is not the case for most patients who have a mild or asymptomatic COVID.
We move on to another question, which is about microthrombi, which we hear a lot about in COVID. But the question here to Vincenzo is, have microthrombi classically associated with fetal growth restriction potentially in COVID? Have they been associated with the virus itself or with vaccination?
So there are many complications associated with COVID in pregnancy. In the mother, we discussed before, higher risk of mechanical ventilation, of ending up on ECMO and intensive care unit, and even dying. But for the baby as well, you mentioned fetal growth restriction. There's good evidence that preterm birth, especially if you have severe or critical COVID infection, is increased, maybe fetal death, some reports preeclampsia, etc. So yes, there are many reports that have been fascinated by them of COVID infection causing microthrombi in the placenta. And there are wonderful reports and now systematic reviews of those, and especially in mothers who are really sick. We do know that there is an inflammatory, cascade, and again, in fact, we should anticoagulate women who have severe COVID, and maybe even therapeutically anticoagulate women who have critical COVID or intubated in the ICU. So that happens, and I think actually going back to some of the earlier questions, I think the vaccination and even booster vaccination will protect the baby from any of these complications. The mother doesn't get very sick, doesn't get COVID at all. And so all of these complications will be prevented, FGR or IFD, microthrombi, etc. So really, really important vaccination. In terms of the vaccine, I haven't seen any reports of that causing microthrombi. The microthrombi come from COVID infection. Like you said beautifully, Chris, the vaccine, especially the mRNA, after they make antibodies, they dissolve, so they don't cause any problems in the baby or the placenta.
Good. Hopefully that'll dispel some myths. So thank you, Vincenzo, for that. We'll move on to the final specific question, and then we'll go to some general points. So to Ray, what are the factors for mortality in pregnant women with COVID-19 infection in Mexico?
Well, I think not only in Mexico, but in the world. Well, we have published, I think we have more than 14,000 pregnant women with COVID and approximately 200 maternal deaths now in Mexico, which is a lot. And I think since last Congress, we have already published that maternal age, for example, is a risk factor for death, pre-existing diabetes, chronic hypertension, obesity, chronic renal disease. Also, asthma is a risk factor for maternal death. But we were wondering what's going on, why in Latin America we have so many deaths. And we also analyzed two very important things that could be related. One is the social vulnerability index, and the other is poverty. And well, maybe not surprisingly, but we found that women with a very high social vulnerability have higher risk of death, while those with a very low social vulnerability index, they have lower risk of death. And also poor woman has higher risk of death. So that was like very shocking for us. It's not access to healthcare services, it's everything else around that woman that will increase her risk.
Yes, Ray, this is a very interesting question because ethnicity, social class, pre-existing medical conditions, obesity, hypertension, there are so many things that come together in the sort of metric, in the algorithm of risk. And it is fascinating that with COVID, more perhaps than with any other illness or virus, that we've actually seen all these factors an interplay with one another. And that is yet to be completely elucidated, isn't it? Because many of these factors depend on one another. So more work to be done here. So question to Andrea here, are there any long-term side effects of the vaccine in pregnancy?
Well, thank you again for the question. Well, I think this is a very important occasion to state firmly that there is no evidence concerning the evidence on the long-term adverse events for the mother, for the baby, and for the pregnancy itself related to the administration of the COVID vaccine during pregnancy. So on this basis, the recommendations for all the pregnant women are to get their vaccine while pregnant at any trimester, ideally prior to the third trimester, because it has been proven to carry benefits for the pregnancy itself. So that's for sure my answer to the question.
It is worth noting in this context that long-term effects of vaccines are exceedingly unusual if we look at vaccines in general. So the adverse effects are usually, if there are any, would be picked up relatively quickly. Asma's nodding her head, so I assume do you have anything to add on that response, Asma?
Well, I think in terms of the safety of the vaccine, I think we should reassure pregnant women that I don't think we have any concern that the vaccine can harm the mother or the baby. There are studies which are collecting data. I think talking to pregnant women, I think it's often they have no concern about themselves. The main concern is about the baby and the development of the baby. And just back again to the trial that I mentioned earlier, the PrEP-COV trial that we launched in the UK, we are following up with babies until the age of 1 year. So hopefully we'll have even better quality data.
That certainly sounds like a trial that needs to be done. So good luck with that. Asma, what have we learned since the start of the pandemic? Please give me a really succinct bullet point answer. I'm going to go in the order that is on my screen here. Vincenzo, Asma, Ray, Andrea. What have we learned since the start of the pandemic, bearing in mind the pandemic is only really 18 months old? Vincenzo.
Oh, we've learned a lot. There have been thousands and thousands of papers in pregnancy and COVID. We've learned that the virus can affect women, that women actually get worse compared to same age non-pregnant women, that again, they have more severe and critical disease and they can even die more often. We learned that the baby can be affected because the baby can be born too early if the mother is very sick, can die, can have severe consequences. I think the most important thing that we've learned is that pregnant women, therefore, should be even more than other adults. There are risks more than other people. They should be on the top of the pyramid to get the vaccine sooner than other people and be protected. And it should be sold, like Asma said, in terms of protecting not only them, because they don't care about themselves that much, but they care a lot about the baby. So sell them on the fact that if they stay healthy, they can protect the baby and have a much healthier baby. And in fact, if you get the vaccine during pregnancy, that protection for her and the baby can last for a long time as those antibodies get transmitted in utero.
Thank you, Vincenzo. I'm going to actually ask the same question to Asma. What have we learned since the start of the pandemic?
I'm going to give you a very short answer. We should embrace technology. We could not have carried on living and communicating the way we always did without the technology. And therefore, I think for me, I learned that I should embrace the technology and get the best out of it.
Thank you. Ray.
Well, from our perspective in Latin America, I think we have learned that we were not ready for such a pandemic and that we really needed more quality in our health services, and we need to take care of our population in order to avoid these extreme situations of more high mortality and pneumonia and things like that.
Thank you, Ray. Andrea.
Yes, we've learned a lot of things in pathophysiology, etc. But most importantly, we've learned how to cope with that, how to protect ourselves. So healthcare professionals, we've learned how to manage our patients. And now with vaccines, we have an important weapon to target this infection.
Thank you all. Excellent answers. What do we need to look at in terms of research or clinical management going forward? We'll start with Ray.
I think we need to look forward at all the possible factors that may be related to adverse outcomes in our population, not only those that are clinically easy for us to measure, but all those socially implicated in a disease like this.
Okay. Thank you. Andrea?
Okay, so I think that also coming back to my former questions, I think yes, we definitely need to know more in the long term what is going to happen, and particularly looking at vaccines. We know how to handle patients, how to manage patients, pregnant patients with COVID, with mild disease, with severe disease, etc. We don't know that much in the long term concerning the vaccine effects. At the moment, as I said, no evidence of adverse events. In the future, we don't know, but it's our job to see what may happen.
Thank you very much. Asma.
The world suffers from a huge gap in health equity, and we need to support women advocacy. We need to ensure that women's health and the health of their unborn babies are best served, whether during the pandemic or even when it's over.
Thank you. Vincenzo.
I think we need to make sure that new developments in non-pregnant adults get implemented as soon as possible in pregnant women. We saw what happened with remdesivir, with dexamethasone, with therapies that help women. Same thing with the vaccine. We can't wait weeks, months. We can even wait days. We need safety data for women, for vaccines, and for interventions. And we also need to be on the lookout for new variants, of course, and how they can affect pregnant women.
Thank you very much all. Thank you so much to our panel, to Vincenzo, to Asma, to Ray, to Andrea. We are sorry we missed Leona from this discussion, but she was very much with us and has, of course, given us a lot of contribution to the questions and answers. So I look forward very much to our next time when we can meet, perhaps in 6 months' time or 12 months' time, when we know a lot more about vaccines. Can perhaps tell us about that. Microthrombi, Vincenzo. Ray can tell us about the social demographic risk factors, and Andrea and I have been looking at the very interesting variations at the start of the pandemic between mortality ratios and actually the prevalence of the virus in the population. All these areas are still open for discussion and are going to be fascinating to understand many of the drivers underlying these differences and changes. So thank you very much, everyone. Thank you so much, ISUOG, to Kate, to Nazia, to Maxine for making this possible. And I really hope this is going to be instructive for you all that are joining us for this. Thank you very much. Goodbye from me.